Good morning, everyone. This is Mark Erkin, and welcome to our Friday morning Tyro Journal Club. It is really a pleasure to have you back and look forward to this morning's session. I do want to call your attention to Tyro, which you can access through the website that is identified at the bottom of your screen. We encourage you to take a look at this initiative, and we would love to get your feedback on the platform and how you get your comments regarding its usability and value to you. We will be continuing to work on Tyro and continuing to add to it, but we welcome your feedback. With respect to this morning's program, it is really an honor and a privilege for me to introduce Dr. Electron Kebebew. He is currently Chief of General Surgery at Stanford University, a position that he has held since 2018. Prior to that, he was a senior investigator at the NIH, where he became the first chair of the endocrine oncologic surgery branch. He was there from, I believe, 2012 to 2018, and was extremely prolific in the development of that particular branch at the NCI. He has published over 400 scientific articles, as well as several books and chapters. He is currently the editor-in-chief of the journal Thyroid. He has been widely decorated and received multiple awards from the American College of Surgeons, the American Thyroid Association, the American Association of Cancer Research, as well as the American Association of Endocrine Surgeons. He was the second author on the recently updated guidelines from the American Thyroid Association related to anaplastic thyroid cancer. And so he is presenting this morning on current approach to that devastating disease process. If I were to say how much has changed in the management of anaplastic thyroid cancer in the last several years compared to the first part of my career, it has been a dramatic change in this devastating illness. And so I think it's of tremendous value for us to hear his perspectives, as well as that of the collaborators on the American Thyroid Association Guideline Committee. And so I welcome him and encourage all of you to send in your questions, and we will try to get to as many as possible by the end of the session. So with that, we will go ahead with Dr. Kebebew's presentation.
Good morning. It's a pleasure to be here with you at the Thyroid Head and Neck Cancer Foundation Virtual Journal Club. I'm going to be talking about the 2021 new American Thyroid Association Anaplastic Thyroid Cancer Guideline. My name is Electron Kebebew at Stanford University, and I had the honor of co-chairing this guideline committee with Keith Bible and then 19 other members, so I'm speaking on behalf of the entire task force. I have nothing to disclose. Provide you a brief overview of what I'm going to talk about. First, I'll go over the guiding principles in developing guideline and the management of patients with anaplastic thyroid cancer, as well as important definitions and classifications, and then treatment options that patients with anaplastic thyroid cancer have, and highlight some of the guideline recommendations and good practice statement. I could step back. This guideline was in development over 3.5 years. The first initial meeting of the Anaplastic Thyroid Cancer Guidelines Task Force was at the 217 annual American Thyroid Association meeting. This was an iterative process where the task force met bi-weekly after developing questions to address in the new guideline, with subsequent meetings at each of the annual meeting of the 2019 annual meeting where we reviewed the drafts of the Anaplastic Thyroid guideline. As you could see, there's complete engagement of all of the committee members. Was the composition of the guidelines committee membership. As I said, I had the honor of co-chairing this with Keith Pleibel, who's a medical oncologist. I'm an endocrine surgeon. In total, it included 19 expert members that were selected and accepted by the American Thyroid Association Board of Directors. These were 11 of which were new members from the last guideline and first guideline that was published. They represented 13 institutions. And what's really unique about the Anaplastic Thyroid guideline is it had all of the expertise involvement. ENT, head and neck surgeons, endocrinology, medical oncology, radiation oncology, pathology, methodologists, but patient advocates, as well as one member each of medical ethicists and a basic science researcher. What I'll try to do in the next 50 or 45 minutes or so is really provide a summary and guide for providers in these guidelines. Reason for the development of an updated guideline document was obviously the American Thyroid Association intends to update guidelines in the management of patients with thyroid cancer every 5 years. It had been 9 years since the last guideline, and certainly we will all agree there's been tremendous new discoveries and developments in understanding the pathogenesis of anaplastic thyroid cancer, as well as advances in the evaluation of patients that really necessitated an update to come into compliance with the change in practice. Task force meetings and decisions, as well as the logistics. Like to point out all of the recommendations were agreed upon by consensus. In some cases, this took a great amount of deliberation. There was an assessment of the quality of evidence, and this was decided by the two methodologists that were part of the task force, not the writing group or content or clinical experts. We considered only published and peer-reviewed data when we cited it in the guideline. And we paid attention to developing useful and user-friendly display items. So you might ask, what are the major changes in this updated new anaplastic thyroid cancer guideline? There's 4 really important things I'd like to emphasize. Early somatic genomic interrogation now affects therapeutic decision-making in anaplastic thyroid cancer, and the use of personalized therapy is thus now really a seminal part of the revised guidelines. As I mentioned already, enhanced display items were developed to improve the user-friendliness, readily accessible topics, questions, and recommendations. And in this new guideline, we added good practice statements, really to highlight important practices and to supplement specific evidence-based recommendations. And again, the quality of evidence was decided by 2 expert methodologists, not by content experts. What are the important steps in the management of anaplastic thyroid cancer? It's establishing the diagnosis rapidly, as well as engaging a multidisciplinary team, as well as evaluation of the extent of disease. Many of these things are done simultaneously. Patient counseling and really organizing treatment goals and objectives of the patient. Evaluation of surgical options and determining whether the patient has surgically resectable disease. Decision of go to surgery or no go should be done rapidly, as well as non-surgical decision making, post-operative or primary chemoradiation versus palliative radiotherapy, systemic therapy, or best supportive care. An initial discussion of end-of-life care and goals of care. So once you're establishing the diagnosis, this really, as I mentioned, requires a multidisciplinary team engagement and immediate assessment of the extent of disease and counseling. So what do I mean establishing the diagnosis? This often will involve a needle biopsy, and in some cases may require a core needle biopsy. And multidisciplinary engagement is to really coordinate the involvement of surgeons, radiation and medical oncologists, endocrinologists, and palliative care team. All of these specialties focused should be on the patient and could occur in simultaneous consultation. But really, the main thing we emphasize is that this care should be coordinated and discussion amongst all of the different specialties. And it is essential that this be done in a rapid time is of the essence in the evaluation and treatment of patients with anaplastic thyroid cancer. The initial assessment, as I said, is to establish the diagnosis. And when evaluating the extent of disease, this often requires anatomic imaging. We recommend that patients undergo neck, chest, and abdominal CT scans, an FDG PET if available. Bone scan may be useful if the patient likely has symptoms of bone metastasis, and a brain MRI with or without contrast to exclude brain metastasis if clinically indicated. What is unique, unlike thyroid cancers, is the molecular interrogation. We recommend that the biopsy specimen be tested for a BRAF mutation, as well as the immediate assessment of the airway with laryngoscopy and securing the airway if necessary at this initial evaluation. The patient counseling includes surgical counseling, and it really should be provided by an individual skilled in the management of complex thyroid cancers with tracheal invasion and esophageal invasion. Once there's been an immediate establishment of the diagnosis, assessment of the airway as the extent of the disease, unlike other thyroid cancers, as you all know, anaplastic thyroid cancer is stage 4. The distinction is between stage 4A, 4B, and 4C, where 4A represents an anaplastic thyroid cancer within the thyroid gland without regional or distant metastasis. And again, this is a clinical staging based on imaging. Stage 4B is a locally advanced anaplastic thyroid cancer with involvement of lymph nodes, but no distant site of metastasis. And stage 4C is the presence of distant metastasis. Another concept is the assessment of surgical intervention. R0 designates complete resection with negative microscopic margins, where R1 resections are grossly complete resections, but with tumor involvement at the surgical margins, and R2 resections is that there's gross positive margins at the time of resection. This is important because the goal of surgical intervention in anaplastic thyroid cancer should be complete tumor resection, that is R0 or R1, and not debulking. The tumor resectability should be curative, as I said, with negative margins, and in some instances might require en bloc resection of visceral structures. The two important criteria when considering if the tumor is resectable is the extent of disease. Does the patient have stage 4C disease? And what are resectable structures? And what is the morbidity and mortality of the procedure itself? Now I'm going to spend a great deal of time on really the initial treatment based on the assessment of the extent of disease. If the patient has localized anaplastic thyroid cancer, then we encourage definitive intention therapy because of potential for long-term survival in patients with stage 4A disease. Again, with the goal of an R0, R1 resection, emphasizing that these patients should not have debulking surgery, as well as fairly morbid surgical interventions such as laryngectomy, the reason being that these patients most commonly fail locally or distant site. These patients then go on to have definitive intentional radiation with IMRT, with or without radiosensitizing chemotherapy. Patients with stage 4B disease. Again, the initial assessment really should be the determination of whether the disease is resectable. The algorithm follows that if it is surgically resectable, similar to patients with stage 4A disease. If the patient does not have surgically resectable disease, during the rapid diagnostic workup, which really should take no more than 1 week, assessment for BRAF mutation should be performed. In many instances, immunostaining for the BRAF B600 mutation is fast and is positive in most BRAF mutant anaplastic thyroid cancer, but parallel comprehensive genetic testing may need to be performed and should be performed to confirm the mutational status. If the patient has a BRAF mutant, they should receive combination BRAF MEK inhibitor treatment where there has been reports with exceptional response. In some cases, this has allowed the residual disease or remnant disease to be resected. If the patient does not have a BRAF mutant stage 4B anaplastic thyroid cancer, the molecular interrogation could potentially identify targetable mutation such as ALK fusion, RET fusions, or NTRK fusion, where there are available agents that target this. I would like to emphasize, as you can see on my top of the slide, in these instances, clinical trials are strongly recommended if available for those specific agents that target the mutation or genetic rearrangement or fusion. And the discussion of best supportive care or hospice option really should be a reiterative discussion with the patient from initial diagnosis to staging, and even if once they've embarked upon treatment, based on the assessment of the quality of life and their goals for treatment, as some of these treatments may have morbidity, side effects associated with it, and also the assessment of the response to that treatment. There have been reports that patients have had exceptional responses to targeted therapy and as part of larger clinical trials, and some, once they have an excellent response, that surgical intervention may be an option. How about the initial treatment choices for patients with stage 4 anaplastic thyroid cancer? The critical decision-making process, again, after discussing in a multidisciplinary team and identifying what the goals of care is for the patient, is whether they would like to have aggressive care. If the answer to that question is no, then they should be provided the best supportive care. if the patient would like to have aggressive care, this, again, evaluation would include for mutation status assessment for specifically BRAF V600 or the other mutations that might be present and that are targetable. And again, this should be done in the context of a clinical trial. There have been reports where patients have responded remarkably well to combination BRAF and MEK inhibitors where their disease response allowed surgical intervention. A key point during this decision process is, in some instances, logistically, the molecular testing results might not be available. And we present the concept of rich systemic chemotherapy and radiation until this information is available, and in some instances could take up to 2 to 3 weeks. One should also consider palliative cytotoxic chemotherapy or external beam radiation in these patients for symptom relief. Also, in patients with stage 4C anaplastic thyroid cancer, and this also includes some cases that don't respond to initial treatment selection, if they have high PD-L1 expression or high tumor mutational burden, that immunotherapy with checkpoint inhibitors may be effective. Again, preferably, this should be considered in a clinical trial setting if available. For the rest of my presentation, I'm going to highlight what I feel are the important recommendations and best practices. The first recommendation of the guideline during the rapid diagnostic evaluation of patients is that FNA cytology can play an important diagnostic role in the initial evaluation of anaplastic thyroid cancer, but one should strongly consider parallel core biopsy for definitive diagnosis, as well as to obtain sufficient material for molecular interrogation. Strong strength of recommendation for the low quality of evidence. The second recommendation in the guideline is that every effort should be made to establish a diagnosis by biopsy before proceeding with surgical resection, as surgery may be inappropriate. Strong recommendation with low quality. Recommendation 5 in the guideline addresses the question that molecular studies should be performed at the time of anaplastic thyroid cancer to inform decisions related to the use of targeted therapies, especially as there are now FDA-approved mutation-specific therapies in this context. Strong strength of recommendation with moderate quality of evidence. Recommendation 6 states that the initial radiologic tumor staging should include cross-sectional imaging, in particular CT scan of the neck, chest, and abdomen and pelvis, with MRI if CT is not available, as well as FDG. And that patient should have contrast-enhanced imaging of the brain to exclude brain metastasis. Strong strength of recommendation and moderate quality of evidence. This is unlike other thyroid cancer patients that we take care of. Recommendation 8, we emphasize that comprehensive disease-specific multidisciplinary input should be obtained before defining patient goal of care or undertaking therapeutic discussions with patients. Those involved in the management decision should include specialists highly experienced in treating anaplastic thyroid cancer, strong recommendation with low quality of evidence. And the guideline actually identifies some centers and experts as resources for the reader or the practitioner evaluating a patient with anaplastic thyroid cancer. Recommendation 8 discusses that patients should be encouraged to draft both an advance directive in which they name a surrogate decision maker and list a code status and other end-of-life preferences. And some documents are publicly available, such as the post and most, and circumstances where suspension of DNR or and may occur must be discussed with the patient as well. In recommendation 14 of the guideline, we state that given the poor overall prognosis of anaplastic thyroid cancer, morbid radical procedures, including laryngectomy, tracheal resection, esophageal resection, and/or major vascular mediastinal resection that may otherwise delay other life-extending therapies should be avoided. Recommendation 15 emphasizes that following R0 or R1 resection, we recommend that good performance status patients with no evidence of metastatic disease who wish an aggressive approach should be offered standard fractionated IMRT with concurrent systemic therapy. For recommendation 16 in the guideline, we recommend that patients who undergo R2 resection or have unresectable but non-metastatic disease with good performance status and who wish an aggressive approach be offered standard fractionation IMRT with systemic therapy. Alternatively, those patients who have a BRAF V600E mutated anaplastic thyroid cancer can undergo combined BRAF and MEK inhibitor treatment and should be considered in this context. Recommendation 17 states that in patients with unresectable disease during initial evaluation in whom radiotherapy and/or systemic therapy renders the tumor potentially resectable, that we recommend reconsideration of surgical resection. This is becoming more and more a common clinical scenario where we have exceptional response to targeted therapy in patients with anaplastic thyroid cancer, and surgical intervention in these patients can result in durable responses. Recommendation 20 states that amongst anaplastic thyroid cancer patients with unresectable or advanced disease wishing aggressive therapy, we recommend early initiation of cytotoxic chemotherapy, even if awaiting mutational interrogation results or targeted drug availability as a bridge approach, as stated earlier. In recommendation 21, we state that patients with BRAF V600 mutation, stage 4, and an unresectable stage 4B anaplastic thyroid cancer patients wherein radiation therapies decline, that initiation of BRAF MEK inhibitors is recommended over other systemic therapies if available. Now, as many of you know, the guideline is several hundred pages long. And what I have tried to do here is really highlight the main changes, the reason for these changes in the new American Thyroid Association guideline for the management of patients with anaplastic thyroid cancer. I have listed here resources, the actual PDF of the guideline is available for download at the website that you see there. Also, Keith Beidel and I have a video introducing the guidelines, again, highlighting many of the important aspects that I shared with you this morning. There's also a user-friendly pocketbook of the recommendations and good practice statements relevant to the initial evaluation of patients and diagnosis, as well as treatments that is available, as you can see here. To wrap up the presentation of the new American Thyroid Association guideline on the management of patients with anaplastic thyroid cancer, I'd like to highlight again and emphasize key aspects in the initial evaluation, the diagnosis, and treatment of patients. The initial evaluation and diagnostic workup should be performed preferably within a week of the patient's presentation. I want to emphasize, unlike other patients with thyroid nodule, if the patient presents with a clinical history of a rapidly expanding mass, think that an FNA diagnosis, biopsy, might not be diagnostic, and consider doing a core needle biopsy in these patients if you have any clinical suspicion of anaplastic thyroid cancer, and that this sample should also undergo molecular testing to hopefully identify targetable driver mutations. Unlike other patients with thyroid cancer, patients with anaplastic thyroid cancer require immediate evaluation of the extent of disease with anatomic imaging, namely CT scan and FDG PET if it's available. As soon as you have established the diagnosis, this is a disease process that patients will significantly benefit from having a multidisciplinary team taking care of them. And this engagement should be focused on the patient, but the communication should be free and fast amongst all the different specialties. And once this is done, then a treatment plan and management plan could be presented to the patient, but also the patient having consultation with palliative care to identify their goals for treatment. Once the diagnosis is established, then the optimal management strategy, as I emphasized to you, could be selected based on the extent of disease. And the other thing I'd like to emphasize is the assessment of the patient's wish and treatment alternative should be an iterative process once treatment is initiated. And lastly, patients should be provided options of clinical trial if they do not have FDA approved or standard of care treatment options. Thank you again for the invitation to join you and go over the new anaplastic thyroid guideline. As you could imagine, unlike normal journal articles, it would be impossible for me to go in detail over all of the recommendation and good practice statements, but I hope I've given you the important take-home message.